Hi friends, this is a routine case. The patient is 62-year-old male with some posterior subcapsular cataract and cortical cataract component. In this video, I will tell you the components of and pearls of planning for a topical case in your first few sessions. To start with, first most important thing is that patient selection is very important. Start with a cooperative patient and take care, avoid anxious patient and those with very strong blink reflex initially that you can see while examining the patient or the slit lamp or while doing the biometry, they will squeeze their eye too much. Also avoid dense cataracts or complicated cataracts like a small pupil patient with pseudo exfoliation that can be handled better after you gain the experience doing lot of cases in topical anesthesia. You should also counsel the patient properly and tell them the realistic expectations. Inform that during surgery they will feel mild pressure and fluid sensation. Also tell them that they need to be calm during the procedure and the eye should be kept still during the surgery. That is very important. Under anesthetic techniques, you can use proparacaine drops, 2-3 drops preoperatively. I give in both eyes so that if some irritation is there in the other eye which are not operating, so they should not squeeze that also. And if needed intraoperatively, you can repeat that also, but take care that it should be fresh. Every drop you are using in the OT should be fresh. The date should be written on that. In our OT, we don't use any drop which is open more than a day. We discard the same day and all are with the dates. You can use lidocaine jelly also preoperatively, or it's good if you can use intracameral lignocaine that comes as phenocaine these days, very effective, a combination of tropicamide, phenylephrine, and lignocaine. You can supplement the anesthesia also. You should always have a backup like a subtenance block ready or a peribulbar block ready if patient has discomfort. And if you feel that patient is very anxious, you can have a IV midazolam in presence of your anesthetist also. In topical cases, you should always use screw speculum. Wire speculum is not very good for stabilization of eyes and lid pressure handling, but you should take care that the screw speculum should not be very tight because that will also lead to lid stretching and pain for the patients. Here we have reached till capsular axis. Here the patient should be informed that we are doing a very important step. They should not move their eyes. Once you did the capsular axis, further steps are easy because you have one phaco probe and one dialer or chopper stabilizing the eye. Now decompressing the anterior chamber by washing the visco from the anterior chamber. It's time to do hydrodissection. You should always do first hydrodissection, multiple quadrant, followed by this hydrodelineation. You will observe a beautiful golden ring if your hydrodelineation is proper, as you can see here. Patient is constantly instructed to look above the light and we talk to them, keep them calm, ask them if there any pain or stretching they are feeling. Now we will start the phaco procedure. We'll enter into the eye in phaco 1. We have planned stop and chop. This cataract is little bit soft. Here my settings are vacuum 80, power is 50 and flow rate is 25. You don't need too much vacuum at this step and not too much flow rate. A good trench is formed end to end, a deeper in the center. In soft cataract, you have to be careful while making the trench, and the power calibration should be proper because sudden emulsification of the nucleus in center can cause rent also if you go deep and apply more power. Any air bubble coming in the view should be aspirated. It's very important when you are doing topical phacos, you should plan your surgery each and every step in your mind to minimize the surgical time so that the patient is cooperative whole during the surgery. The fluidics and phaco settings, you can use a little bit low bottle height. Normally we use 100 centimeter, you can use like 80. Always any case which is complicated like any high myop patient, polar cataract, the main criteria is to do low pressure, low flow phaco. The fluidic should be slow. There should be no turbulence. Same in topical phaco, you should optimize the vacuum and flow settings to prevent any fluid surge and minimize patient discomfort. And sudden pressure changes during phaco should be avoided. You should also be ready to manage the complication. Be prepared for the patient movements, sudden blinking, squeezing reflexes, and don't hesitate to take out your probe if you feel you need to inject visco. It's okay to take out your probe 2-3 times. Initial cases of topical phaco and pushing visco to give a proper space for phaco. We are in phaco 2. The vacuum here is 380, power is 50 and flow rate is 45. It is the other D part of the nucleus. We are emulsifying. There is a small cup formation. So I am trying to lift it carefully and brought it into the center. Now emulsified and will slowly aspirate it. This patient was diabetic, had multiple injections intravitreal, and finally when there was no macular edema, we planned for the cataract surgery. So in these cases, these soft cataracts are a little bit sticky also, so that you have to keep in mind. Phaco 2 is completed, complete ampinucleus and nucleus is removed. Here I am seeing a small component of posterior polar for safety. Before taking out the phaco probe, I am injecting visco. Whenever you have any doubt that there is a posterior subcapsular cataract with a polar component and the patient is diabetic, having multiple intravitreal injections, so there you should take care that there should be no PC rent. It will deteriorate the retinal condition, will increase the edema and have a long-term effect on the patient vision. Now it's time to do the cortical wash. Now we will be using our coaxial IA. Here the vacuum is almost 400 and flow rate is 40. My preference is coaxial because I'm using it from starting. Only in few cases where I need to retract the iris or polar cataracts, I use bimanual. In general, I am comfortable with coaxial. You can use anyone, whichever you are comfortable. My coaxial has a bend at the end. It's not a straight coaxial. Subincisional cortical wash is easy with it. Again, pushing visco as I was suspecting some component of polar cataract. So your case is never finished in polar components until the patient is out from the OT. Even after putting the lens, while forming the chamber, you can have a PC rent. So any case where you are expecting any polar component, you should take care at each and every step of the surgery. Now we are injecting the lens. It's Hoya 250 preloaded lens with multi-cert injector. In these diabetic patients, it's always advisable to use hydrophobic lenses. Avoid using hydrophilic lenses. These days, we are not using hydrophilic lenses in any case because there are high chances of PCO. And here, we can use advanced monofocal lenses if patient pocket allows, but trifocal and EDOF lenses are not advised as patients have retinal problems, multiple intravitreal injections are given, previous CMO was there. So best solution for patient here is putting a good hydrophobic monofocal lens, or if they want, you can use an advanced monofocal lens. Doing the AC wash of visco. Angle should be cleared properly. Now my favorite step, going behind the IOL, lifting the edge of the IOL and wash behind the IOL. The visco wash behind the IOL helps like maintaining the pressure next day, and it gives you a practice especially for toric lenses where visco wash behind the IOL is very important to avoid any post-operative rotation. Now it's time to form the chamber. Here you can see one thing I was observing, that my tunnel was not complete 1.5 mm in length. It is a little bit shorter. But the chamber formed well. I didn't felt like putting a suture. There was no iris prolapse, chamber formed well. Proper hydration was done. If you feel any leakage in these cases, you should put a suture also. As you can see in zoom, that the tunnel length is little bit less than 1.5 mm. Chamber is formed well. The case is completed. Thanks for watching.